In this video, I'm going to look at the drugs affecting the renin angiotensin aldosterone system, the angiotensin inhibitors. These drugs are used chiefly in the treatment of primary hypertension, directly affecting one of the body's main physiological mechanisms in controlling electrolyte and water balance. The drugs I'm going to look at fall into one of three groups really, and are classified based on which part of the renin angiotensin aldosterone system they affect. These three classes are the angiotensin converting enzyme, or ACE inhibitors. An example of this is captopril. The angiotensin II receptor blockers, or ARBs. An example of this is losartan. And a direct renin inhibitor, which is called aliskiren. I want to start by giving a brief recap of the renin angiotensin aldosterone system, which I'm going to call the RAS in this video to save myself a bit of time throughout, as you can see, it is a bit of a mouthful to say repeatedly. The RAS is perhaps best visualised as a cycle or flow diagram composed of three distinct yet interacting parts. So let's explore these a bit. We can firstly identify renin, which is a molecule produced in the kidneys and released from renal juxtaglomerular cells into the bloodstream. The angiotensin portion refers to really three different compounds: angiotensinogen, angiotensin 1, and angiotensin 2. These molecules are protein structures and share similar chemical structure, differing only by the different numbers of amino acids that they contain. These compounds really are the key players in terms of the pharmacology used to affect the system, and the ACE and angiotensin II inhibitors possess high clinical efficacy in treating primary hypertension in a variety of different patient groups, but particularly in diabetes patients due to their additional cardioprotective effects. And I'll come on to look at this in greater detail at the end of the video. I'll explore the drugs affecting the aldosterone part of the system in the next video, when I take a look at the thiazide and related diuretics. So before I dive into the pharmacology, I think the best way to start is to first get a visual idea of the key players in the mechanism by reviewing the normal physiology of the system. So take a look at the sketch I brought up here, and let's explore the various parts of the system and how they all interact to alter the complex salt-water balance mechanisms that end up leading to a raise in blood pressure. Let's work through this step by step. So things all start from the release of renin, and this is from renal juxtaglomerular cells. And this occurs because of one of three things. It either occurs because of reduction in sodium chloride concentration in the bloodstream, and this is sensed by distal convoluted tubule cells in the kidneys. It can also be released due to reduction of blood pressure being picked up by renal afferent arterioles. And finally, renin can be produced because of sympathetic stimulation of beta-1 adrenoceptors present in renal juxtaglomerular cells themselves. So what does renin do? What we can say is that it cleaves or breaks off amino acids from the molecule angiotensinogen. And this happens when it comes into contact with it in the bloodstream. And this is just a chemical reaction, as at the end of the day, it would happen anyway, but because renin is a protease, a protein-breaking enzyme, it greatly speeds up or catalyses this process, as the two molecules are complementary chemically. This in turn causes the inactive angiotensinogen to become the active angiotensin 1. So let's leave it there for a moment and look at the pharmacological side of things. So if I tell you that at the end of this whole mechanism, the overall physiological effect of renin release is to increase blood pressure, and I will go on to explain the reasons why this is shortly, then do you think that perhaps drugs which can inhibit renin production directly and block the mechanism at the start of the cycle could be useful in treating hypertension patients? So if you guessed yes, then you'd be right, as a direct renin inhibitor has been produced indicated for the treatment of hypertension, and it is called aliskiren. So in terms of its pharmacodynamics, aliskiren is classed as a direct renin inhibitor. It acts competitively for the angiotensinogen substrate, possessing a similar active site to renin, differing only in the fact that it does not break off the amino acids that will turn angiotensinogen into angiotensin 1. Aliskiren's role in overall hypertension management has yet to be fully explored, but theoretically it is a potential avenue that is perhaps more direct in blocking the renin angiotensin aldosterone system than perhaps the other agents that I'm going to mention later on in the video. So in terms of pharmacokinetics, a dose of 150 to 300 milligrams is indicated for hypertension, and this is given once daily through the oral administration route. However, looking at the drug licensing information available, the side effect profile of aliskiren appears somewhat higher than the other RAS-inhibiting drugs available, and an MHRA warning exists regarding concomitant use with other angiotensin inhibitors, especially in diabetes patients, and this is due to severe renal and cardiovascular outcomes, such as an increased risk of stroke. This perhaps explains why the drug isn't in widespread use, despite its apparent positive pharmacodynamics. Also, as the patents of the drug are still active, and therefore no generic agent is available as an alternative, the branded products do tend to be extremely expensive to prescribe, and this perhaps is another reason for the hesitancy in recommending these drugs when looking at the overall hypertension guidelines. So let's get back to looking at the RAS mechanism, and take a look at what happens after renin has catalysed the transformation of angiotensinogen into angiotensin 1. So when our newly formed angiotensin 1 molecule circulates through to the lungs, it is further reacted with, and further amino acids are cleaved off it to produce the highly bioreactive angiotensin 2. This process is brought about by angiotensin converting enzyme, or ACE. And this is another protease enzyme that breaks the bonds between adjacent amino acids in the angiotensin 1 molecule. During the conversion of angiotensin 1 to angiotensin 2, ACE concurrently speeds up or catalyses the breakdown of bradykinin, which is a peptide endogenous to the body that tends to produce an overall vasoconstricting effect. By blocking it, a general vasodilation effect is therefore caused. It has historically been described as residing only in pulmonary vascular tissue, but further research has found evidence for ACE being located in a variety of other tissues, just in varying concentrations. ACE is another target of the drugs affecting the RAS mechanism, and ACE inhibitors are perhaps the most well-known angiotensin inhibitor agents used in clinical practice, and I'll come on to looking at a couple of these in more detail. So lastly in our mechanism, we have the effects that occur through our newly formed angiotensin 2 molecule. Angiotensin 2 is now classed as a ligand that is complementary to a class of receptors present in a variety of different tissues. And when these are stimulated, this leads to an overall hypertensive effect. Two types of angiotensin receptors exist in peripheral tissues, AT1 and AT2 receptors. It's worth noting that although these are chemically and structurally different, the current research proposes that all the physiological effects come from stimulation of AT1 receptors, with the AT2 receptors' function remaining largely uncertain. It is possible that future research may provide a physiological role for the AT2 receptor, in the same vein as further subdivisions of the adrenoceptors have been made over time. But at present, the pharmacologic interventions are targeted towards the AT1 receptor specifically, and therefore makes the pharmacodynamics relatively simple. Stimulation of AT1 receptors causes contraction of vascular smooth muscle in the periphery, causing an increase of total peripheral resistance, although this has been found to only be a weakly contributing factor. It also causes the secretion of aldosterone, a hormone produced by the adrenal cortex that has additional hypertensive properties through alteration of electrolyte balance. Binding of angiotensin 2 to the receptor sites in renal proximal convoluted tubule cells causes increased reabsorption of sodium, and binding to angiotensin receptors on sympathetic nerves causes an increased release of noradrenaline. It's worth noting that both angiotensin 2 and aldosterone have an inhibitory effect on further renin release. This allows the system to be controlled homeostatically and presents a negative feedback mechanism. So that's essentially it for the RAS mechanism, and this process occurs constantly to either raise or lower blood pressure as required, with the process homeostatically controlled to allow constant maintenance of water and electrolyte parameters. In times of dysfunction, however, such as that what occurs in primary hypertension, where an overactivation of the system tends to occur, homeostasis is altered and the usual negative feedback mechanisms are ineffective at producing an adequate blood pressure lowering response. So, here is where our angiotensin inhibiting drugs are indicated, to reduce the overall stimulation of the RAS mechanism by targeting a particular part of the process. I've spoken already about the direct renin blockers, so now let's consider the ACE inhibitors and angiotensin II receptor antagonists. So, let's start by considering an example of an ACE inhibitor. Let's look at lisinopril. In general, the ACE inhibitors are all easily distinguishable by their ending in pril, and other examples of these agents include captopril, ramipril, and so on and so forth. So in terms of pharmacodynamics, the mode of action of lisinopril is to selectively bind with the ACE molecule, and this is directly to its active site, therefore preventing our substrate, angiotensin II, from being able to bind. This stops all of the physiological effects that I mentioned before, and therefore leads to an overall reduction in blood pressure. All the different ACE inhibiting agents differ only by their chemical or functional group used to bind with the zinc atom present on the active site of the ACE molecule. This is really a purely chemical thing, and doesn't really have any particular pharmacodynamic interest, but may potentiate certain adverse drug reactions such as abnormal taste sensation. But I'm getting ahead of myself a bit, and I'll discuss this bit more in the next section. Lisinopril is indicated for primary hypertension, and is particularly good for this purpose, exerting its pharmacological effect with relatively fewer side effects when compared with other antihypertensive agents. ACE inhibitors like lisinopril are indicated in mild to severe primary hypertension, and are considered first-line agents for stage 2 and above hypertension in many different patient groups, per the advice published in the 2011 NICE Hypertension Guidelines. Their widespread use is in part due to the added protective pharmacodynamics, with efficacy studies showing ACE inhibitors to be extremely useful in managing hypertension when it presents with concomitant heart failure, myocardial infarction, chronic kidney disease, or type 2 diabetes. These drugs are said to concurrently possess renoprotective and cardioprotective properties. In terms of pharmacokinetics, lisinopril undergoes considerable first-pass hepatic metabolism, with only a 25% bioavailability reading when using a normal preparation. However, as do other ACE inhibitors, it possesses a good half-life lasting on average for around 24 hours, and this allows a once-daily administration route to be considered. ACE inhibitors all tend to produce similar antihypertensive results, but their effects can be augmented by concomitant use with other angiotensin inhibitors or with thiazide diuretics, and sometimes they are packaged as combi drugs. Using lisinopril as an example of this, it is commonly combined with hydrochlorothiazide to increase its antihypertensive properties. The main adverse drug reaction of lisinopril, but really this extends to all ACE inhibitors, is the development of a persistent dry cough secondary to the accumulation of bradykinin. As I mentioned before, bradykinin is an endogenous chemical that when broken down promotes vasodilation. The degradation of bradykinin is blocked by ACE inhibitors, and therefore this leads to excessive bradykinin levels in the bloodstream, which is then free to interact with various receptors in the body. In the lungs, this causes bronchoconstriction, leading to the cough development. Other reported adverse drug reactions include dysgeusia, an abnormal taste sensation secondary to the interactions between the drug and the zinc atom present on the active site of the ACE molecule. This effect mainly occurs in captopril, however, and is thought to occur due to the interaction between this drug's sulfhydryl group with the zinc atom and the ACE molecule. The use of lisinopril is cautioned in patients with bilateral renal artery stenosis, or really any other renal pathology that results in severely reduced glomerular filtration rate, as its angiotensin-converting enzyme inhibiting properties prevent the physiological correction mechanisms that would occur to increase efferent arterial pressure when faced with low GFR. Concomitant use of lisinopril with potassium-sparing diuretics or potassium supplementation is additionally advised against due to the risk of hyperkalemia, or elevated potassium levels. Let's now move on to looking at those drugs affecting the terminal end of the RAS mechanism, the angiotensin II receptor blockers, or ARBs as they're also sometimes referred to. Examples of these agents include losartan, candesartan, and valsartan, and I'm going to use losartan as an example drug in this section. All of these agents are equally easily recognisable as part of this drug class, as they all end in the same suffix, which is sartan. ARBs were released secondary to ACE inhibitors as the drugs used to inhibit the RAS mechanism. The pharmacodynamics of all the agents in this class is a competitive inhibition of angiotensin II of AT1 receptors in a variety of peripheral tissues. The overall effect of this is to reduce aldosterone secretion from the adrenal cortex, reduce vasodilation of peripheral arteries, reduce the sodium reabsorption from the nephron, and decrease the release of noradrenaline from sympathetic nerve terminals. So essentially this is all the opposite physiological effects that would occur if angiotensin II was able to bind to the AT1 receptor. ARBs are chiefly used in the management of primary hypertension and tend to display equal efficacy to ACE inhibitors, but with the added benefit of reducing adverse drug responses. This is through the degradation of bradykinin no longer being inhibited, given that ACE is no longer targeted, and therefore bradykinin levels don't rise to excessive levels and therefore cause the dry cough. For this reason, ARBs are sometimes prescribed as an alternative to ACE inhibitors, following the reports of adverse drug responses on those agents. An additional pharmacologic effect again includes a protective role in the development and progression of cardiovascular and related pathologies, with losartan, for example, possessing cerebroprotective effects, and telmisartan shown to possess positive effects on overall insulin sensitivity. This property of the drugs, in addition to the fact they have no effect on glycemic parameters, perhaps suggests ARBs are best suited to patients with concomitant diabetes and hypertension, and this is reflected in current NICE guidelines, with ARBs considered first line for this patient group. In terms of pharmacokinetics, ARBs are prepared as oral tablets and may be combined with ACE inhibitors or low-dose thiazide diuretics, such as hydrochlorothiazide, and these combi drugs allow enhanced antihypertensive effects and therefore provide a whole range of different treatment strategies for patients with hypertension which are not able to be controlled, as the textbook or guideline suggestions would make out. What is recommended, though, is that ARBs should not be combined, and especially not in diabetes patients, with the direct renin inhibitor aliskiren, nor should it be combined with potassium-sparing diuretic agents or potassium supplements due to the increased risk of renal damage and hyperkalemia in this patient group. The bioavailability of ARB drugs is variable, but is usually considered poor at anywhere between 15 to 40% depending on its preparation. However, like most ACE inhibitors, they tend to possess a good half-life of around 24 hours, and this allows patients to only have to require a once-daily administration of the drug, effectively streamlining the drug scheduling process. As a final point, I think it's worth mentioning that certain drugs in this class have been redesigned to improve the pharmacokinetics of the class. For example, candesartan has been designed as a prodrug to increase its bioavailability, as this property allows it to exert its pharmacologic effect without having to undergo extensive first-pass metabolism in the liver, just so that an active metabolite can be formed that can then bind to the AT receptor in various tissues. However, the efficacy of this is highly variable and is really dependent on the non-pharmacologic parts of the medicines that this drug is prepared with. This video has been an overview of the drugs affecting the renin angiotensin aldosterone system. We call this group of drugs the angiotensin inhibitors. To review, the renin angiotensin aldosterone system is an important physiological mechanism in water and electrolyte homeostasis. A stimulation of this system promotes an overall increase in blood pressure. The system is essentially a cycle composed of the interaction between short-chain protein structures, enzymes, and angiotensin or AT1 receptors. Drugs affecting this system fall into either the categories of angiotensin II receptor blockers, or ARBs, angiotensin converting enzyme, or ACE inhibitors, as well as the direct renin inhibitor, aliskiren. These drugs are chiefly used in the management of primary hypertension, with current NICE guidance recommending their first-line use in patients under 55 years of age. Diabetes patients have been shown to benefit from the secondary cardiovascular protective properties of these drugs when hypertension has presented with concomitant heart or renal disease. In the next video, I'm going to look at thiazide and related diuretics. I'll look at a couple of common agents in this group and round off things by looking at the bit of the renin angiotensin aldosterone system I've left out, the aldosterone antagonists.